Welcome to Unit 8 in Transitioning to Value-Based Care on Population Health for Value-Based Care. This is the last unit in this MOOC. In both lectures in Unit 8, we're going to focus on what many are terming population health. Essentially, in the first lecture, we're going to discuss definitions associated with population health, distinguish between population health and precision medicine, and then start to look at some specific tools and models of care which can help support value-based care going forward. We will complete this discussion in the second lecture in Unit 8 and also address the ever-changing landscape in healthcare. Population health or population health management seems to have become buzzwords in the last few years, with such disparate meanings that the terms have almost become meaningless. Still, it is important for us to consider the terms being used and what they may mean in any given context. Let's start our discussion by parsing out the concepts and defining each word in turn. Population certainly has had a specific definition for a very long time. In general, population has referred to the total number of persons inhabiting any district or area. How many people live in your hometown, in the United States, in the world? This is a pretty indisputable definition of population. Understanding a given population helps in affording a governance structure to balance the interests of all stakeholders and their safety, education, health, etc. In healthcare, population often has referred to the individuals receiving care within a system of health, such as a hospital, physician, nursing home, etc., or whose care is financed through a specific health plan or other entity. This is different than a geographical population, as any given geographic area could have several hospitals, for example, and certainly many different physicians. Some individuals may seek care in only one of the hospitals or a few of the physicians, but we are free to go to any hospital, whether near or far, to where we live, work, or play. In value-based care, however, the term population takes on some additional attributes beyond geographic. In some forms of value-based care, most notably the accountable care organizations initially set up by CMS, individuals may get attributed to given providers, typically who are within a geographic area of the individual's residence, even as the ACO, for purposes of risk, may be a single large integrated delivery system with facilities in several states or even disparate facilities across the United States, which have come together due to some other form of affinity to share risk, such as rural health care facilities, cancer institutes, etc. When Medicare first started its value-based care program, unless a Medicare beneficiary was already being seen by a given provider, CMS attributed Medicare beneficiaries essentially randomly based on geographic location. Similarly, some health plans attributed members to providers if they had not seen a provider within 1 or 2 years of the formation of the value-based care arrangement. More recently, individuals are seeking to assign themselves to providers. We're going to discuss provider attribution or assignment further in a bit. But in summary, with respect to value-based care, population may encompass geography, individual preference, and sometimes also certain segments of health needs, such as all low birth weight babies or elderly persons with complex needs. So a pretty complicated movement away from just where we live, work, and play to something much more than that. In contrast to the term population, the concept of population health is much newer. It was first defined by Kindig and Stoddard in 2003 as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. This definition was later expanded by the Institute for Healthcare Improvement in 2014 to life expectancy, mortality rates, health and functional status, disease burden, that is the incidence and or prevalence of chronic disease, and behavioral and physiological factors such as smoking, physical activity, diet, blood pressure, body mass index, and cholesterol. Jacobson and Tooch in 2012 also defined population health. Their definition was a cohesive, integrated, and comprehensive approach to health, considering the distribution of health outcomes in a population, the health determinants that influence the distribution of care, and the policies and interventions that impact and are impacted by the determinants. Interestingly, Kindig, the author of the first definition in 2015, has suggested that the definition from Jacobson and Tooch is more appropriate for current usage within the provider community. It seems actually that the two primary definitions have useful information and are not necessarily contradictory. But it does seem that Jacobson and Tooch provide the broadest possible scope and especially encompass not only a way to describe the current state of health affairs, as in the Kindig and Stoddard or IHI definition, but also include accountability for addressing the health needs of a population. In a 2015 survey of 37 chief executive officers and other health leaders, one respondent noted that population health signifies the movement from a silo-focused delivery of medicine to a communal effort with the purpose of improving the overall health outcomes of a population. This statement highlights distinctions between health and medicine, as we've previously discussed, with population health being focused on broader determinants of health, and population medicine being focused on evidence-based interventions and disease management to triage and allocate healthcare resources in a cost-effective manner. Given the need to address not only those who seek medical care, but populations needing both medical and health care, Partners Healthcare, which is a provider-sponsored health plan who was one of the true pioneers in value-based care, has described population health management as a collection of activities not reimbursable in the fee-for-service model, but important in the care we deliver our patients, including primary care, specialty care, non-hospital care, patient engagement, and analytics and technology. This list of factors or components of population health management enumerated by Partners Healthcare seems to be what most users mean when they refer to what is population health management. These factors not only reflect the comprehensive scope of the population to whom health care is delivered and the shifting of risk accordingly, but also reflect that in order to be successful with this level of risk, all determinants of health need to be addressed in the process of delivering medical and health care. The list of factors described by Partners Healthcare has been expanded or nuanced by others, but are essentially the factors we're covering in this unit, with primary care being essentially the general contractor for individuals who at any given point may need specialty care, non-hospital care, their own engagement in their health and wellness, which we call patient engagement, and who needs to have analytics supported by technology to manage the population's health and medical care and be able to manage risk so that both the quality and cost of health improves. So now let's look at, well, what's the difference between population health versus public health? Population health was first defined by Winslow in 1920, a long time ago, as the science and art of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society, organizations, public and private communities, and individuals. Today, the Centers for Disease Control and Prevention, CDC, expands on that definition and provides a distinction between public health and clinical professionals. CDC describes public health as the science of protecting and improving the health of people and their communities. This work is achieved by promoting healthy lifestyles, researching disease and injury prevention, and detecting, preventing, and responding to infectious diseases. CDC also distinguishes between public health professionals who try to prevent problems from happening or recurring through implementing educational programs, recommending policies, administering services, and conducting researches, versus clinical professionals like doctors and nurses who focus primarily on treating individuals after they become sick or injured. CDC also notes that public health also works to limit health disparities. A large part of public health is promoting health care equity, quality, and accessibility. It seems to me at least that population health and public health, while having distinct roles, are also coming closer together. Now let's take a look at population health versus precision medicine. The two statements on this slide, on first blush, would suggest that population health and precision medicine are not aligned. Dr. Eric Topol of Scripps Translational Science Institute and Chief Academic Officer for Scripps Health in 2017 is quoted as saying, "Population health is fundamentally flawed in its approach. One-size-fits-all approach to medicine through population health management is a losing proposition. What's urgently needed is a personalized approach to health care that treats individuals, not populations." Another quote of his is, "The individual makeup of each person can lead to better prevention, treatment, and more effective health care." He is encouraged by analytics, artificial intelligence, genomics, as well as machine learning in generating actionable insights about individuals. The second quote on this slide is from the National Institutes of Health in 2017. "Precision medicine is, quote, an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. This approach will allow doctors and researchers to predict more accurately which treatment and prevention strategies for a particular disease will work in which groups of people. It is in contrast to a one-size-fits-all approach in which disease treatment and prevention strategies are developed for the average person with less consideration for the differences between individuals." Having read these statements closely, it seems to me that both statements are maligning one-size-fits-all and that both are looking to the same medical science and health information technology to overcome healthcare value issues of today. The argument that population health is treating everyone the same, however, seems to be a common one among physicians who have always and rightfully feared that something or someone is forcing them or will force them to standardize their practices and rely solely on evidence and practice guidelines to treat patients. It is for this reason that many physicians are also conflicted about bundled payment, for example, in value-based care. It would seem that it is a safe way to manage risk. To many physicians, it is interpreted as a requirement to address the treatment associated with the bundle in a cookie-cutter manner, even as joint replacement bundles have spurred several very recent innovations. In fact, this interpretation is why CMS continues to not yet mandate bundled payment use as recently as its September 2017 announcement. In this discussion, I'm reminded of the discussions we've had on ethical decision making in Unit 2 and the evidence-based medicine triad reproduced here in Unit 4. That individual clinical expertise, best external evidence, and patient values and expectations come together as evidence-based medicine. Those are not three separate and distinct elements, nor is evidence-based medicine only one or two of those three elements. It would appear that population health and precision medicine have the same goals and can and should coexist with one another.